Good afternoon. My name is Dr. Priya Kumar, and I'm a GP partner, Health Inequalities Lead, and Population Health Lead for Kumar Medical Centre in the United Kingdom in Slough. I'm also a Senior Clinical Advisor for PPL and working with the National Primary Clinical Care Research with regards to the population health approach to primary care, which is what I will be talking about today. Our journey really started post-COVID. We are a small practice of about 5,592 patients, 96% global majority, one of the most deprived populations in Frimley with 10.7% diabetic prevalence. Most of the rest of the system is at 6%. And the diabetic control significantly deteriorated post-pandemic. And there was also the recruitment of the additional roles, something known as Rs in the UK. So we had new service providers and healthcare providers, such as physicians associates, pharmacists, social prescribers, care navigators. And pre-pandemic, I had about 8 staff. Post-pandemic, I had 26 half-time equivalents, and I didn't really understand how to use them within the system, as well as we were losing continuity of care with regards to our patients. So our segmentation journey really started in June 2021. As I'm aware, in Australia, many of you are fully aware of the Johns Hopkins segmentation tool, and we started to use the patient need group with understanding of the complexity of our patients at every triage point within primary care, with reactive care, but also within proactive care. And as you can see by this diagram, this is the whole of Frimley. We had roughly 800,000 individuals within our population, and 71% were low need, moderate need about 19.7%, and high need of 2.3%. And by understanding the background health of the individuals prior to the presenting complaint, we decided to start to redesign clinical services. And within Kumar Medical Centre, we first put that into the unscheduled care. So how could we optimise by understanding the complexity of our patients, that they were sent to the right service, whether that's digital or redirection, or within the practice, to the right healthcare professional first time. And then in April 2023, I'll talk in a bit more detail, we even took that to our long-term conditions chronic registers. And what we were really trying to do was release capacity and time by shifting care to the left so we could address health inequalities. So within KMC, we did 3 primary drivers, the technology, which was Johns Hopkins, but what was really important about this was about context launching it in the native EPR, so our clinicians and non-clinicians could see at a glance the complexity of the patient in front of them. We redesigned our clinical pathways, both reactive and within our long-term conditions. So instead of people being seen by date of birth, they started to be seen by complexity with regards to their long-term conditions, and we educated our staff, not only our clinical staff, but obviously our non-clinical staff. So the allocations of appointments could be significantly more productive. And we had some ideas with regards to the change. We thought we'd have greater use of the technology to enhance patient access and continuity of care, align complexity to the right service and right healthcare professional first time, avoiding duplication of services, proactively improving the health of our patients prior to winter, which would release capacity not only within our practice, but also within the wider system, improve staff satisfaction, patient satisfaction, and resilience. And patients would access us in multiple ways: walk-in, telephone, via e-consultations, which were all new things that came through COVID, as long as they didn't have a red flag symptom, such as chest pain, fever, rash. Segmentation would come into play. Our non-clinical staff would understand patient need group 1 to 11. And for example, there was another service known as Pharmacy First that was introduced in the UK at that time, where community pharmacies would see 7 conditions such as cough, skin cellulitis, or ear infections. And what we started to see was that if we sent patient need group 5 and below, 75 to 90% of those people would be sorted out within our practice. If we sent anybody 8 and above, only 31% of people would get sorted out, and the majority of them would come back within 3 days. So within our practice, we changed our reactive care with regards to redirection, and nobody patient need group 5 and above is sent to pharmacy first, because we know that will only block our system again within 3 days. The other thing was that we were able to align GP partners and more senior GPs to the more complex patients, and the more junior staff to 5 and below, as well as using these new recruitments, the physicians associates and the pharmacists, in a completely different way according to complexity. And as mentioned, with regards to the long-term conditions, in England previously we would see patients by date of birth. So someone born in December could have a worse outcome than someone born in May. And what we started to do at Kumar Medical Centre in April 2023 is see people by complexity. So we would see people 11, 10, 9, 8 at the start of the year. And we would also start to use digital services such as text messaging for 5 and below. So for example, those that were hypertensive, in patient need group 3, we would send 200 text messages. We would get roughly 50 to 55 back. 52 of them would be normal and 3 would be abnormal, saving 52 appointments with the nurses or the clinical pharmacists. And at every point, we were trying to maximize the digital services as well as our workforce complexity. So for example, the other thing is my most senior nurse would see patient need group 8 and above who could manage their diabetes, change their medication, and would just ask me to sign the prescriptions, whereas our junior nurses, where the HbA1c control was probably more improved in 4s and 5s, would generally see these patients. Same with our senior pharmacists. They would see 8 and above, so they can de-prescribe medication, versus 5 and below with the junior pharmacists that would do the easier medication reviews. So at every level, we were trying to maximize the efficiency. So what did we see? In July 2023, what we saw was that we'd seen 10% more of our most complex patients compared to the rest of the system. And we'd also seen 8% of the 4s and 5s using digital. That minus 7.1 in low need adults with cervical smears, which would not affect winter pressures, and there was a seasonality to this, and minus 6.1 was the low need children that we were bringing in August 2023 in the summer holidays. What did we see within our practice? We saw a release of capacity of 13.7% year on year. We saw less green patients, we saw more amber patients, and the red patients were status quo. And rightly so, some of my colleagues were saying that, well, if you saw less green patients, they just turned up to A&E. That was not the case. We saw a reduction in A&E. We saw a reduction in admissions as well as total bed days. And we predicted this, that if we were to get the baseline morbidity of our patients better prior to winter, their blood sugar better before winter, asthma control or COPD, that there would be that impact in the wider system. And as you can see from our results with regards to our long-term conditions, we only achieved 67% in 2022 prior to bringing in the system. In September 2023, we had seen 90% of our population prior to winter and 87% in 2024. But what was really important was the control going into winter. We had 70% of our population controlled in 2023 and 75% in 2024, showing this rolling effect. Furthermore, we had 8% more patients with an improved HbA1c less than 75 and 5% more below 58. Therefore, really moving from this reactive way of working to a proactive way of improving people's baseline prior to winter. And as you can see here, you can see the whole of our population health approach to all the services we deliver in primary care. Interestingly, for example, the non-users within the system, we have looked into the data, identified anybody who's a non-user over the age of 40 and bringing them in proactively for health checks, because we know that they're not using the system and it's important to ensure that we're addressing health inequalities. And really what's key to all of this is by shifting care to the left, we were able to do community social prescribing, we work with the voluntary sector, we've set up things like digital buddies, where we're able to bring people in with our social prescribers to understand how to use the NHS app, which is our new digital front door. Furthermore, we were able to do home visits for families that were not engaging with us. There were many multi-generational households in Slough, and we'd do the immunisation for the children, the checkup for the parents, and the diabetic checkup for the grandparents, all in the same households that were not engaging with us. So really starting to address those health inequalities. And this is all we're really trying to do, is provide a population health approach to shift care to the left to really shape healthier communities in the future. Thank you for this opportunity, and I hope you found this valuable. Take care.